Welcome to the Cure HHT Education Webinar Series with tonight's topic, the International HHT Guidelines for Brain Vascular Malformations. I'm Nicole Schaefer, Director of Professional and Medical Programs for Cure HHT, and your moderator this evening. Before we begin, I'd like to give you a little bit of background about the International HHT Guidelines. In 2008, Cure HHT hosted the first International HHT Guidelines Conference, which was led by Dr. Marie Faughnan and produced the first internationally recognized HHT guidelines in 2009. 10 years later, Cure HHT hosted the Christopher McMahon Memorial International HHT Guidelines Conference, which was only made possible by a very generous donation from the McMahon family. This event was led by Dr. Marie Faughnan from the University of Toronto, Dr. Stephen Hetz from the University of California, San Francisco, and Dr. Hans-Jürgen Mager from St. Antonius Hospital in the Netherlands. And it involved over 60 HHT patients and physicians from around the world. The result was the publication of the second International HHT Guidelines in the Annals of Medicine this past September 2020. Cure HHT created fact sheets for each topic area along with the guidelines recommendations, all of which have been bound in this comprehensive guide to managing your HHT. We're providing the first copy of this guide complimentary to all HHT patients and providers. So if you haven't received your copy yet but would like one, please complete the Join Us form on our website, and I'll be posting that link in the chat after we begin. If you ever have questions related to HHT, want to help raise awareness through a grassroots event, or need educational materials for you, a family member, or your physician, please contact Cure HHT office either by email or phone. This information is also listed on our website at www.curehht.org. So now it is my pleasure to introduce our speaker. Dr. Marie Faughnan is a pulmonologist and director of the HHT Centre of Excellence at St. Michael's Hospital in Toronto, Canada. As I mentioned before, Dr. Faughnan chaired both international HHT guidelines conferences and played an instrumental role in the publication of both sets of guidelines. In addition, she's the lead principal investigator for the Brain Vascular Malformation Consortium study for HHT, better known as the BVMC study. These accomplishments make Dr. Faughnan the perfect speaker for tonight's presentation. But tonight we also have two special members of our panel. Leanne Tilley received an HHT diagnosis at the age of 15 when she suffered a stroke caused by a cranial AVM. She is experienced with every type of treatment for cranial AVMs, having had multiple embolizations, radiation treatments, and craniotomies. Leanne is the only person in her family with cranial AVMs, but also has lung AVMs, nosebleeds, migraines, and telangiectasias, and is cared for by Dr. Faughnan and her team at the St. Michael's Hospital HHT Center. Leanne is passionate about patient advocacy and has chosen a career in healthcare in large part due to her own experiences as a patient. Today, she will talk about her experience as a participant in the BVMC study. And Leslie Perry is a registered nurse with a master's in science and is the BVMC research coordinator at Cure HHT. Leslie recruits patients with brain AVMs, whether they've been treated or not, into the study if they have not been to one of the recruiting HHT Centers of Excellence. At the end of the presentation, all panelists will be available to answer your questions. So let's begin our program. Dr. Faughnan, as you bring up your slides and your camera, let's launch our first poll. And the question is, do you or a family member have HHT and a brain vascular malformation and just check as many as apply. And we'll give you about 25 seconds. Okay, let's stop it there, and I'm going to share the results. So Dr. Faughnan, this is at least a snapshot of who's in our audience tonight.
Thank you. That's really helpful to see. Well, thank you so much for this invitation and kind introduction. And I just want to welcome everyone tonight. I was really looking forward to doing this webinar and to talking to you about the guidelines, but also about, I think, the ingredients for improving future care for brain vascular malformations. And that's why I'm going to put the guidelines into the context of current care. Guidelines are kind of about where we're at currently. And then also talk about the Brain Vascular Malformation Consortium, or the BVMC, which is the major brain VM research endeavor going on in North America for HHT patients. So sorry off the bat already for all of these acronyms, but I know that we'll get a chance to repeat them, and I promise to be as clear as I can about all of them as we go. So I'm going to start by just defining the problem of brain vascular malformations, talking about the diagnosis briefly, how we treat them, what are some of the treatment modalities. And then I'm going to spend most of the rest of my time talking about what the current approach to brain VMs is in HHT in terms of screening and treatment, and really highlighting that even in 2021, we have a major challenge deciding which brain VMs should be treated and which might be better not treated. And I'm going to finish by talking about the BVMC, the Brain Vascular Malformation Consortium research, and how we are trying to find answers to this most difficult question about which brain VMs should be treated, and talk about the people that are contributing and sharing their stories to help us find those answers. You'll notice right off the bat that I'm talking about brain VMs. It's not because I've forgotten that there's an A there, but brain VMs is actually a broader term to talk about brain AVMs and other smaller brain vascular lesions or abnormal blood vessels in the brain of people with HHT. So it's not by mistake, and I promise I'll define a little further in a moment. So to come way back to the beginning, just in case, get everyone on the same foot, HHT is an autosomal dominant disease. In other words, a hereditary disease that's inherited in a dominant fashion, and it's present in about 1 in 8,000 people. And it's characterized by vascular malformations, or VMs, which of the skin, of the mucosal membranes, and of the organs. The very common features of HHT are the telangiectasia of the skin and mucosa, as shown here. And eventually we will see these in approximately 90% of adults. Of course, the most common symptom of HHT, which I don't need to tell most of you, is recurrent nosebleeds. And that eventually becomes a symptom in 90 to 95% of adults with HHT. However, the organ vascular malformations, or organ AVMs, are also important features in HHT, though frequently unrecognized. They are often unnoticed, in fact, until they present with a hemorrhage or a big bleed or other complication. And yet there's a role for prevention of these complications in HHT. So if we look by organ, about 10% of HHT patients will have AVMs in the brain, about 40% in the lung, and then about 30% will have smaller VMs or telangiectasia in the GI tract, and 75% in the liver. So though these organ manifestations of HHT are often unrecognized, they are actually also common features of HHT. So I'm going to in a moment really speak much more specifically about brain VMs. But just before I do, one final slide about how we diagnose HHT. So we use the clinical features that we just talked about as kind of the mainstay for diagnosis of HHT, based on the nosebleeds, organ AVMs, the telangiectasia, and the family history. And we also, in the last almost 20 years now, have the capacity to use genetic testing for diagnosing people in the family who don't have all of the clear clinical features yet, often younger people in the family. Okay, so now specifically about the brain. So brain AVMs are present in about 10% of people with HHT. They range in size and in shape, and they're often multiple. About 50% of the brain AVMs that are found in HHT are found in early childhood and probably present from birth, and about 50% seem to develop during adolescence. Many will cause no symptoms or problems, though some do cause serious complications such as stroke, usually by a bleed in the brain, which we'll call intracranial hemorrhage medically, or ICH. I'll make sure to remind you of what I mean by all those terms as we go. But the serious complications from brain AVMs can be a bleed, aka stroke, seizures, and death. So these are obviously very, these are terrible complications, and they occur only in a small percentage of HHT patients, but clearly these are complications we want to prevent. So what is the key to caring for people with brain AVMs, to caring for people with HHT and brain AVMs? I think the key is to identify those brain AVMs that are at risk of bleeding and treat those. And probably also the second important thing is to avoid treating those brain AVMs, which are maybe not ever going to cause any complications. So I'm going to talk about this whole concept in detail as we go through the rest of my slides. So just a word first about how we diagnose brain vascular malformations. Typically, we'll use an imaging in radiology that will show details of the blood vessels in the brain. And most typically we use the MRI, but sometimes the CT scan with contrast. And then often we will confirm the diagnosis with what is called a brain angiogram. So MRI and CT are very similar types of modalities. I mean, they're different in the sense that they use different technologies, but in both cases, we obtain cross-sectional images. So sort of like pictures that are slices through the brain, and we can use special sequences to be able to highlight the blood vessels. So in this example, these are different sequences of this patient's MRI. And in the bottom one here, you can see that this small brain AVM becomes very visible, very easy to recognize because of the sequence that's used here to highlight the blood vessels. So this is kind of a very sort of basic presentation of the idea of the type of imaging that we need to use to identify brain AVMs. This is an example over here of a brain angiogram in a patient with a particular type of brain AVM, or brain VM, I should say, called an AV fistula. And I'm going to explain that more in a second. But first, I want to explain what a brain angiogram is. It's another way of imaging the blood vessels in the brain. But when we do an angiogram, what we actually do is inject an X-ray dye into the blood vessels of the person with the HHT. And we do imaging of the brain where we can really see very specifically the blood vessels, and none of the other tissue is interfering in the image. And it gives us very detailed imaging of the lesion, of the size of it, of where it's located, and a lot of the characteristics of it, of the blood flow through it, etc. So these are the types of imaging in general that we use to diagnose brain AVMs. And I've shown you these examples as we go too, because I also wanted to show you that there are several, let me just check, okay, that there are several different types of brain vascular malformations in HHT. And I'm just going to run through the three main types here. And now you'll understand why I was talking about that the broader topic of brain VMs includes several different types of lesions. So a brain AVM is a typical artery to vein connection in the brain, where and this is an HHT that, we do see brain AVMs, and they're often on the small side, but there is a range, and I'm going to show you some numbers about that in a second. But brain AVMs that we see in HHT are more kind of comparable to the kind of brain AVMs that patients who don't have HHT have, can and are perhaps more similar to the kinds of studies that have been done in non-HHT patients. And so I guess I'm not explaining this well. When we first started trying to understand brain AVMs and HHT, all we had was medical literature, medical evidence from what we call sporadic AVMs, because these were brain AVMs in people that don't have HHT. And we kind of used that as our guide to, okay, let's assume that the brain AVMs and HHT are like the ones that in people that don't have HHT, and then we can apply what we know about the non-HHT brain AVMs to treatment of people, to treatment of brain AVMs in HHT patients. But what we realize is that there's really only this type, is the brain AVM type, that's similar in any way to this what we call the sporadic brain AVMs, whereas that patients with HHT also have two other types of brain vascular malformations. These really teeny tiny ones called capillary malformations, and they're maybe more like the telangiectasia we see in HHT, and then larger high flow ones called an AV fistula. And so this description of the different types of brain AVMs and HHT was a very important step that allowed us to begin to try to make clear to clinicians and to researchers in the area that HHT brain AVMs are not the same as sporadic AVMs, that HHT brain VMs have a really different makeup. So if we look at the HHT group, and this is from the BBMC study, about 64% of the brain vascular malformations that we saw in the first 125 HHT patients that we recruited, 64% were these teeny tiny ones called capillary malformations. And about 27% were the sort of traditional kind of AVMs that are seen in sporadic patients and also other organs in HHT. And that the high flow AV fistulas that I was telling you about, that I showed you the angiogram of, that was about 9% of the lesions. And also, by the way, about 44% of the patients in our first series here from the BVMC had multiple brain vascular malformations. Whereas if you look at the sporadic brain vascular malformations, pretty different makeup. So they're almost all AVMs, almost no capillary malformations or AV fistulas, and almost never multiple. And then this last line here too is a difference between those two. And you'll see that the AVM and AVMs larger than 3 centimeters are typical. So about 55% of people with sporadic brain vascular malformations. So just to remind you, that means people that don't have HHT, but that just have a brain vascular malformation. About 55% of them will have an AVM that's bigger than 3 centimeters. Whereas in our first 75 patients in the BVMC, there was nobody that had an AVM that large. Okay, so all of this tells what, is sort of our way of telling the world that we need HHT specific brain VM research, because brain VMs and HHT are not the same as the more typical and commonly known sporadic AVMs. So to summarize so far, brain VMs and HHT there's several different types. There's a range of size. And I want to tell you too, and I'm going to speak some more about this, but there is a range of risk of bleeding. So as I mentioned before, when we talk, one of the things we worry about the most with brain VMs is is that they might rupture and bleed, and that's called an intracranial hemorrhage. And that the risk of bleeding based on clinical experience seems to be that it varies with the lesion type. AVMs are not the same as capillary malformations, are not the same as AV fistulas. But there has not yet been a big enough series of patients with HHT and brain VMs to really clearly demonstrate that, to really say, okay, this is the risk with each type of lesion. The other things that we know from experience or that we that we think are the case is that the risk of bleeding will vary with lesion size, with maybe location in the brain. And then we have a bunch of other things that we think might influence the risk of bleeding from a brain VM and HHT. Maybe inflammation, maybe genetics, maybe the presence of other disease, maybe lifestyle, lots of other questions that I'm going to come back to when I talk about the BVMC. So we've talked a bit about the diagnosis of brain vascular malformations in HHT, and we've talked a bit about the risks of intracranial hemorrhage. But now we're going to speak specifically about treating brain VMs in HHT. The big challenge about in the treatment of brain VMs in HHT is the need to balance the risk of ICH, in other words, intracranial hemorrhage or bleeding from a brain VM, with the risks of the treatment. It would be quite an easy decision if the treatments that we had zero risk. But as you know, most of you would know, there are almost no treatments like that that are zero risk. And brain vascular malformation treatments are actually fairly invasive treatments that do have a significant risk. So the types of treatments that we have for brain vascular malformations there are three kinds, really. There's surgically removing the brain VM. There's embolizing or blocking off the AVM through the blood vessels, often done with a sort of synthetic glue or other similar products. And the third type is a kind of radiation, which is called gamma knife therapy, which is a focused radiation to shrink down the AVM. So all of these have some risk, and we're talking about risk of neurologic deficit. So a neurologic deficit can be similar, it means that you're left with some symptoms that could be like symptoms of a stroke. So we're trying to prevent intracranial hemorrhage with stroke and risk of death, but we have a treatment that has some risk of neurologic deficit, around 5%. So obviously the balance and understanding the balance of those risks for each person and for each lesion becomes really critical to giving people the best advice. So what are the knowledge gaps in HHT when we're trying to balance this risk? The knowledge gaps are really around around understanding the risk of intracranial hemorrhage in HHT patients with brain vascular malformations and what are the factors that influence that risk. As we've talked about, they can be vascular malformation factors like the type, the size, the lesion, the number, et cetera. And then patient factors, things about the patient or their disease or other health problems or their lifestyle, et cetera. Genetics, et cetera. So these were, these are knowledge gaps presently, but they were even bigger knowledge gaps a few years ago when we started the Brain Vascular Malformation Consortium. And that's in fact exactly why we started it, was to address these types of questions. So the Brain Vascular Malformation Consortium is a study that is a multi-center study funded by the NIH and CATS NINDS. And it involves recruiting across 17 HHT centers, as well as recruiting through Cure HHT. We actually started this study now 11 years ago, and the goals have evolved over time, but they have really been focused on the knowledge gaps that I just outlined for you. The specific aims, though, I've kind of summarized them here because we have specific research aims for each 5-year cycle, but really overall, the first and foremost specific aim of the BVMC is to characterize the risk of intracranial hemorrhage from brain VMs and HHT. And we are also trying to characterize comprehensively other brain outcomes in HHT. The second aim is really to identify genetic predictors and circulating biomarkers that could help identify severe disease, risk of bleeding, severe bleeding, and brain outcomes in HHT. And then third, and this is one of our more recent aims, is to try to define a severe bleeding type in HHT for clinical trial readiness. And this isn't just about brain vascular malformations, this is really about bleeding in HHT in general. And we're trying to use bleeding in HHT as a window, sort of, for example, nosebleeds and GI bleeding in HHT as a window to understand bleeding from brain vascular malformations, as well as an outcome that could help us study and validate new therapies for HHT-related bleeding. So that's the BVMC. Probably our most important early publication was this first publication by Helen Kim as the first author, but by our whole BVMC consortium. So the list of authors is too long to be able to even put in any journal. We have this group author that we call the BVMC consortium that has another 40 authors in it. So these are large collaborations that are occurring across Canada, the US, and the Netherlands, bringing our patients together so that we can, with HHT and brain AVMs, so that we can first hear, this was the first report of a large group of HHT brain AVM patients and what are their risks of intracranial hemorrhage. So we needed to get some numbers on it so that we could begin to understand how to balance that risk against the treatment risk, as we talked about before. Just doing a time check. So we determined that the intracranial hemorrhage rate in our population today, this was in 2014, was about 1% per year. And that we were able to show for the first time a predictor of intracranial hemorrhage in HHT patients. And that was based on what their initial presentation had been. So this is just take a moment to understand this, but this is an important clinical predictor in non-HHT brain VMs, and we validated it in HHT. So if somebody is diagnosed with a brain vascular malformation and there's evidence or a history that they've had some bleed from that brain VM before, then that person has a much higher risk of bleeding from that brain VM. In fact, it's about 10 times higher risk. So if you see ruptured cases, that's what that means. Brain VMs that had previously bled had a higher rate of bleeding going forward, about 10% per year versus 0.5% per year in the patients whose brain VMs had never bled before. So this was, I show you this to show you that we've been able to begin to quantify risk in HHT patients, but also that we can identify, this is just the very first, this was our very first possible measure of it, but we could identify some high risk vascular malformations versus some low risk. I think you would all agree that a 10% risk is a much more significant risk, 10% of bleeding in the next year compared to 0.4%. So this is our first sort of communication. We're trying to say it's really important not to lump all HHT brain VMs together. We need to split them out and understand which ones are high risk and which ones are lower risk. And this was just a very first step at that. Secondly, in the BVMC very early on, we also described the different types of brain VMs. Those images I showed you of the 3 types come from this paper from the BVMC as well. So that was the first large series description of the different types of lesions in HHT. We've also, over the years, and I've tried to summarize this here, looked at the genetics in HHT and how that relates to HHT brain VMs. And I can tell you some of this, salient observations is that brain VMs can occur with any HHT gene type, whether it's endoglin mutation or ACVRL1 or SMAD4. We can find brain VMs in patients with those gene mutations. And intracranial hemorrhage can also occur with any HHT gene type. So in other words, the genetic mutation in a family doesn't tell you whether or not you need to screen for brain VMs. Intracranial hemorrhage, we've also observed across our series, can occur at any age. So it's not just a disease of adults or just a disease of children. It can occur at any age. And there's, from these and some of these observations from the BVMC, we were able to conclude that there's no evidence to date that brain VM screening should be based on genotype or on age. We've also been working on biomarkers and genetic modifiers, trying to understand how how they might be associated with intracranial hemorrhage. And to date, we have not identified any genetic modifiers associated with the presence of brain VMs in HHT or with intracranial hemorrhage, but there's ongoing work in this regard. And as our series grows over the years, you saw our first publication was 75 patients with brain VMs. Now we're up to almost 400 patients that we are following in the BVMC with HHT and brain VMs. We have also been looking for other biomarkers, not just genetics, but other markers that have been identified, other markers that would help predict intracranial hemorrhage or the presence of brain VMs in HHT. And we have identified several candidates. We've identified several biomarkers associated with HHT, different organ involvements, and those will need to be validated, but we have some recent exciting work in that regard as well. We want to identify biomarkers for intracranial hemorrhage as well as for organ involvement, as I was just mentioning. But we want to identify biomarkers for intracranial hemorrhage and other HHT bleeding. And this is work in progress and very much part of our BVMC aims. So, actually just before this next slide, just to a word about the fact that in the BVMC, our priority is to study intracranial hemorrhage and brain vascular malformations, but we have also wanted to take advantage of this large multi-center collaboration to study other aspects of HHT. And so we do actually recruit patients to the BVMC that don't have brain vascular malformations, and we have over 2,000 HHT patients recruited to the BVMC, and we are studying other aspects of HHT in the BVMC recruited population. And in fact, this slide is just to tell you that we're sort of, developing the nose and nosebleeds as a way, as I mentioned earlier, to try and identify severe bleeding phenotypes or severe bleeding types in HHT, and that really might allow us to study novel therapies, but also provide a window to understanding brain vascular malformations. Don't worry about the detail on this slide. It was to remind me to tell you that. So just to summarize about the BVMC. So the BVMC involves investigators in 17 centers and Cure HHT, all recruiting patients with HHT and prioritizing trying to include every brain vascular malformation patient that we can into this series, because the more, the power is in numbers. So we're at almost 400 HHT patients with brain vascular malformations, and we're aiming to get to 600 by the end of this current 5-year cycle, which has just started. And what we're doing, the people that are participating in the trial is that they're joining, not trial, but study. They're joining the study, and we're recording their stories with respect to their brain vascular malformations. We're looking at their imaging with respect to their brain vascular malformations, and we're recording their past stories about whether they've had problems, symptoms, or intracranial hemorrhage, and whether they develop it going forward. And in addition, we're collecting basically blood samples for genetics and biomarkers. So just to put this back into context of where we're at in 2021 and our clinical approach to brain vascular malformations in North America. So we are currently in North America, the standard practice across North American HHT centers is to screen all children and adults with HHT for brain vascular malformations. You'll see that I specifically have switched here into talking about North America, because it's actually quite, there is some variability in clinical practice around the world for many different reasons. But we wanted to, and we published this paper in 2020, we wanted to highlight what the standard clinical practice is across HHT centers to help to continue to define the standard of care for people with HHT. So that is the current standard practice across the 28 North American HHT centers, is to screen all children and adults with HHT for brain VMs. And this is, that screening for brain VM practice has really been in place since the first international HHT guidelines, as well as the screening for lung AVMs, as you can see in this slide, that 100% of HHT centers are screening adults for lung AVMs, 80% are screening children for lung AVMs. And when we talk about brain AVMs, it's 80 and 89%. And interestingly, the sites that are not screening children for brain AVMs, or who were not at the time of this study, it was mostly that they didn't have the local pediatric expertise to provide the screening test. So there's, I think that number, if not already, will soon be 100% across North America. So I want to talk about, I want to come back to the clinical problem, as we said, of the clinical problem that we have when we're deciding about treating a brain AVM and HHT. So we've talked about the fact that we're screening people, all people with HHT, for brain vascular malformations. So what's the next step? The next step, if we find a brain vascular malformation, is do we want to recommend treating it or not? And I think that these two sort of clinical descriptions explain the two ends of the spectrum of the problem. So the first is the 4-year-old girl who develops a stroke or an intracranial hemorrhage from a brain vascular malformation without any warning. And this is the clinical situation where we are absolutely, everyone is thinking, if only we could have treated that brain vascular malformation before the bleed occurred. On the other end of the spectrum, we diagnose a 60-year-old man who has HHT with a brain AVM, but it has never bled. And we think he's probably had it since his teen years. So maybe this AVM is one that isn't prone to bleeding. And maybe this person's AVM is less risky than the treatment is. So these are the types of clinical scenarios that underpin the difficulties that we've had in deciding how to recommend and in deciding on in coming up with systematic guidelines for treatment of brain AVMs. As such, the current clinical approach in North America, and you'll see in the international HHT guidelines, is that if a brain AVM is discovered, that the recommendation is that there be a consultation with a multidisciplinary neurovascular expert team. It's quite a mouthful, but that an expert team looks at all the possible modalities of treatment that could be offered, and looks at the person and their brain VMs and the specifics about those lesions, like the type, et cetera, as we've talked about, and that with that expertise, they make a recommendation about whether or not this brain VM should be treated. So this is what I'm saying, is that right now, that's the current clinical approach, is that we need to use all the expertise we have, all the clinical experience we have to give our best advice to patients, but that we don't have a clear recommendation. If it's this type of lesion, treat. If it's this type, don't treat. We're still in a learning phase and still in a research phase, so that we'll one day be able to get to that kind of treatment algorithm. I'm going to spend the last few slides just talking about the HHT guidelines. Nicole gave an excellent intro to this, and I know that's as I said, is a large part of what my talk is supposed to be about today. But I wanted to put it in the context of the problem, and to say, I think we've already referred to the fact that there were the first international guidelines published in 2009, and that some of the highlights or some of the priorities of the first international guidelines were to develop recommendations around screening and preventative treatment for lung AVMs and for brain AVMs. And in the second international guidelines, we actually focused more on some topics that we had not really addressed in the first guidelines, such as the management of brain vascular malformations in children and also in pregnancy. So the 2020 international guidelines did add some new information and some new recommendations about screening for brain VMs in children. And that's why I said to you before that in 2020, when we looked at standard clinical practice, most of the North American centers were screening children for brain AVMs. But in the same year, we published the international guideline actually clearly recommending this. So this is an international guideline across 15 countries where we recommended BrainVM screening in children with MRI routinely in all children with HHT. So this was new and different and not addressed in the previous guidelines. And the second, I think, important highlight regarding BrainVMs in children from the HHT guidelines was that the guidelines panel recommended treatment of what they called high-risk BrainVMs in children in consultation with a multidisciplinary neurovascular expert team. This is, a different way of a slightly different wording of what I said to you on the previous slide about what the current approach is to BrainVMs. So basically, the wording here is to highlight the fact that if someone with HHT and including a child with HHT is diagnosed with a brain AVM, then that child should have a consultation with an expert team that can offer all the different types of treatment and that can use their experience and the information from the child's imaging to say, to the best of our knowledge, is this a high-risk brain AVM or a lower-risk brain AVM? And if it's a high one, then treatment should be recommended and should be carried out with an expert team. So those are some of the highlights of the HHT guidelines with respect to brain vascular malformations in children. And I've paraphrased here a little bit, but please do find the full details at the hhtguidelines.org website where we have provided free access to the full HHT guidelines documents. With respect to pregnancy, we also clarified in the HHT guidelines process, we clarified how and when to test for brain vascular malformations in pregnant women and whether or not this needed to affect the pregnancy and delivery plan. So typically we recommend, since we're recommending that all adults be screened for brain vascular malformations, all adults with HHT be screened for brain vascular malformations, the best scenario, of course, is that this happened before pregnancy. But sometimes a woman becomes pregnant and hasn't had her BrainVM screening yet. So in that case, we don't actually typically recommend that it be done during pregnancy unless the patient is symptomatic of the brain vascular malformations. But if, oftentimes patients and their doctors do want to have the BrainVM screening done before delivery. And if so, then we recommend that it be done early in the third trimester. The second point is that we were trying during the guidelines to identify which pregnant women with HHT need to be, should be cared for at a tertiary care center, like a specialized care center with a multidisciplinary team, and which might not need to be, so that not all women have to feel that or have to be managed at, have to have their pregnancy managed in a high risk environment. And we said that, that what we recommended is that pregnant women who have a BrainVM, they're known to have one and it hasn't been treated, they should be managed at a tertiary care center by a multidisciplinary team. But it's not to say, and this is the last recommendation here that I wanted to talk to you about, it's not to say that women who have BrainVMs and they're considered to be not high-risk brain AVMs, is not to say that they have to have a cesarean section. That's a bit of a misunderstanding. In fact, typically these women can labor and proceed with a normal vaginal delivery with some modifications depending on the care team's experience. So again, the full details of this are on the hhtguidelines.org access, and I'm really just summarizing here to give you the highlights. So to summarize, what is the current clinical approach in North America with respect to brain vascular malformations in HHT? The current clinical approach is to screen all children and adults with HHT for BrainVMs. Secondly, if a BrainVM is discovered, then you should consult with a multidisciplinary neurovascular expert team, consider all the treatment modalities to decide about treatment. And that third, we need to continue to move research forward regarding markers for intracranial hemorrhage, markers for brain vascular malformations, and new therapies for HHT, so that the next time we give this talk, this slide is significantly different. And the next time we do the guidelines, we have some very specific guidelines around management of brain vascular malformations in HHT patients. I'm going to stop there and first of all, say thank you for allowing me to talk about the guidelines and the BVMC as a subject I'm very passionate about. And I know that Nicole is going to put up the next poll, and then I'm very excited that we're going to hear from one of our HHT patients as well, Leanne Tilley. Thank you.
Thank you, Marie. That was very insightful. I've learned a lot, and I personally have a lot of questions. So if anyone else has questions, I know some have sent them in with their registration. Some people are starting to put them into the Q&A, but feel free to go ahead and put your questions in there now, and we'll get to them once Leanne is done speaking. So if Dr. Faughnan, you can stop sharing and turn your camera off. And if Leanne could please join us. And as Leanne is doing that, we're going to launch another poll, which asks, would you like to participate in the BVMC study? And the answers can be yes, no, I'm not sure, but want to learn more, or I'm already participating. Give it just another second or two. Great, I'm going to end the poll. And Leanne, here are the results of our audience.
I'm happy to see that.
So I will hand the program over to Leanne.
Thank you, Nicole. I just want to say it's an honor to be here tonight, and thank you to Dr. Faughnan and Cure HHT for inviting me to speak. I have a few things that I want to discuss with you tonight. The main one, or main two actually, is why participating in this research study is important to me. If you missed the introduction, you won't know, but over the course of my life, I've had 4 cranial AVMs. One caused a stroke when I was 15. Both of those actual AVMs were treated initially with embolization, one with a craniotomy later on, and the other with radiation later on. I had a reoccurrence in 2018. My team discovered 2 more cranial AVMs. I had an unsuccessful craniotomy and another radiation treatment later on in 2019, and here I am waiting. So considering all I've been through with my stroke and HHT in general, it's a very unnerving feeling to know that I have these inside of my brain again. I know firsthand how a brain bleed can affect somebody, and it's not something that I want to experience again. As a patient, I've often felt that my hands were tied in terms of what I could do to help. But participating in research is one of the ways that I feel I contribute and give back to our patient community. It also feels great to have some good come of my darkest experiences. I don't want what happened to me to continue to happen to others. And I would like patients to be armed with as much knowledge, treatment options, and support as they can be. So what was the process of becoming part of this study? In full transparency, I had to speak with our research coordinator again to remind me of what the process was. I've been in this study for almost 10 years. Basically, it has been so unintrusive to my life that I forget I'm even a part of it. That's how little time and effort it takes on my part. So what happened was basically I was at my follow-up appointments, routine follow-up appointments at the hospital, and the research coordinator was introduced to me by a member of staff. She explained the study to me and asked if I'd like to participate. I signed a consent form. Since I was already doing the blood work, they just added a requisition in to my blood work, and it was completed at the same time. And from that day on, I've received a phone call every year, and all I do is answer questions. It's really that simple. I've been, like I said, participating for close to 10 years, and I can't stress enough just how little effort and time it takes on my end to contribute to something that's so impactful, especially now that I've had my reoccurrence. I encourage others to participate in research in general, but in specifically this study. As a patient and a healthcare professional, I feel research is a vital part of quality patient care and healthcare on a whole. And even though research studies we participate in might not affect us or help us directly at that time, they are sure to help in further education of physicians and patients in regards to the cause, development, and progression and treatment of HHT going forward. It can lead to a better understanding of clinical outcomes for future HHT patients. And for me, that means a lot. Research not only leads to new and innovative ways to treat, educate, and care for patients, it attracts future healthcare professionals to the study and treatment of our disease. And I think we all know how vital it can be in terms of our care and finding a cure. I don't think I'm alone in saying that I've had to educate, physicians outside of my Center of Excellence on what HHT is and how it impacts me. I liken participating in research to lending a helping hand to those who have committed their lives to studying and treating the disease in order to help us, the patients. So I really hope that, you take a look at the Cure HHT website. It does have information about it. You ask your questions today. We are here to answer them. And I hope you will consider, if you're not already a part of this research study, to be coming and, helping out in ways that we can as patients. I don't think I'm alone in feeling like sometimes my hands are tied. You feel the frustration, what can I do? And this is something, and it brings me great joy to know that I am contributing, however big, however small, to something that could help the future patients with HHT. So thank you.
No, thank you. And I just want to thank Dr. Faughnan for thoroughly overview of brain vascular malformations and also the BVM study. And we truly appreciate Leanne's willingness to share her story with us tonight. I know that's not always easy, but I know your story is, you're not the only one with that story. And so I think there's a lot that people feel connected when they, understand that they aren't alone, as you mentioned. So now we are joined with Dr. Faughnan and with Leslie Perry, who, as I mentioned, is the nurse research coordinator at Cure HHT and recruiting patients into the BVMC study. And so I know that we are close to the 8 o'clock hour and we do have a lot of questions. So I think we'll probably go over a few minutes if that's okay with our panelists. Okay, great.
No problem.
So Dr. Faughnan, we have had this question asked about 12 different times and people are very interested to know, how often do I need a follow-up MRI for a brain vascular malformation?
Wow, that's a really good question, and one that we don't have a lot of good evidence to help guide us on yet. It is something that, that the BVMC might shed some light on down the road. But for now, I would say that what we agree on internationally is that we should rescreen kids right up until they're an adult. So in North America and here in Toronto, we're typically screening kids every 5 years from birth until age 20. And then there's no clear recommendation to rescreen an adult once we have a negative brain MRI. Okay, so, but if somebody has symptoms or has any concerns, we have a low threshold to repeating it, but we have not typically recommended, and there's no clear evidence to support repeating the screening in adults. If the initial screen is negative.
Okay, great, thank you.
Thank you.
And the next question is just asking, are children at the same risk as adults in having a stroke or, you know, kind of a catastrophic complication of a brain vascular malformation?
Yeah, good question. So we know that children can have the exact same kind of complications as adults. So children can have intracranial hemorrhage, seizures, can die from brain AVMs rupturing, just the way adults can. We don't have an actual number to be able to say this is the risk in a 5-year-old compared to a 10-year-old compared to a 30-year-old. We don't have that sort of data yet by age, but we do know that intracranial hemorrhage can occur at any age. So, you know, we have no reason to think that a child with a brain AVM is lower risk than an adult with a brain AVM. And that's why our guidelines were really, you know, it was a guidelines priority last year to sort of say we need to address the screening and management of brain AVMs in kids as well as adults.
Great, thank you. So this next question is really probably for all three of you, and it's asking more about the type of information that you are collecting for the study. And then secondary questions tie in about how are those records protected and who has access to the data. So Leslie, do you want to start with just what kind of questions you're asking people and data that you're collecting?
Sure. So we start with just general demographic information, you know, age, date of birth, that sort of thing. And then we go through the history of, you know, when did you first have nosebleeds? When did you first notice telangiectasias? And oftentimes I'm talking to people who have had this for so long, they say, well, I don't know, maybe I was 2 or 3 when I had nosebleeds. I've always had nosebleeds, or I've always had these little red spots. So it's sometimes hard to get exactly the information, you know, exact dates on things. But it's interesting that people have been growing up with it. Often it's their parent. I actually had a call with a gentleman where his mom got on the phone too, and she was actually able to provide a lot of detail that he wasn't really aware of. So it was kind of interesting. And then when I talked to mothers of children, obviously they have the answers, and I've talked to the kids too. So it's a lot of just trying to figure out when you first notice things, and that can be hard, because if you haven't had a family history of it and you get diagnosed, you know, as an adult, you might not really notice when you had nosebleeds or when you had telangiectasias. And then we go into the questions about if you've had brain VMs, what sort of treatment have you had, or have you not had any treatment? How often do you have you had MRIs? Do you have, what sort of symptoms do you have? Do you even notice that you have symptoms with your brain AVM, or is it just not really a problem for you? And then the same questions we also ask about pulmonary AVMs, although that's not as much part of the study. It's just sort of general information. And then have you had any symptoms of other kinds of AVMs? So it's usually the first call is usually about an hour long, the initial call, and then after that the check-in calls, which also I've been doing this summer. Those usually take about 15 minutes. It's about 20 minutes. It really kind of depends on how complicated someone's life has been since the last time they spoke to me or whoever was doing the call. So I've really enjoyed doing it. I think the community is just, they're so well informed about their disease, and it's just so good to see, because in my other life, I'm a school nurse, and I know that people don't really know a lot about what's going on with their bodies sometimes. So I'm really always impressed when people do. So
great. Well, thank you, Leslie. And I know that, you know, Cure HHT obviously isn't a medical institution. So the way that we're recruiting patients and collecting data is a little bit different than the center. So Marie, do you want to talk about that?
Yeah, you know, it's very similar in terms of the kind of questions we ask, but our research coordinator, so after the research coordinator meets with you and explains the study to you, if you decide that, and you go through the informed consent process, and then if you decide you want to join the study, then Once you've signed the consent, then the research coordinator goes through a bunch of questions with you, a lot like what Leslie was describing, but we also have your medical chart, your HHT medical chart that becomes sort of what we call the source document for a lot of the information that we gather in the study. So for example, if you've had a brain MRI then we have, you did that at our hospital and we're recruiting you to the BVMC, then we're able to go and look at the information from that brain MRI and include that as part of your study data. Same thing about your lung screening, et cetera, about your blood work, and these are all things that we kind of explain to you when we ask you, when our research coordinator asks if you want to join the study, we're going to access your records, and these are the kinds of records we're going to access, and then we're going to ask you some questions, and then we're going to put all that information in our database. And then in addition to that, we also typically will collect a blood sample that we collect for the genetic the genetic modifier studies that I told you about and the biomarker studies. There was an important question in there, Nicole, about how we keep the people's information safe, and I want to make sure to answer that. So when we recruit someone to a study like the BVMC, we give them a number. So all the information that we gather about John Doe in the BVMC study is actually under a number and his name is not included in there. So we assign him a particular number, and we don't put his identifying information into the database. We put his medical information all under this number. And that's the information that goes into our BVMC database. And any identifying information about my patient will stay in the hands of myself, the principal investigator, and our research coordinator. We're the ones that know the link between John Doe and his number in the study. So that's kind of the most important thing that we do. And nobody else at the other 17 centers in the study can know John Doe's name. They only know the number when they have access. So our researchers who are part of the BBMC and participating researchers have access to our database, but they never have access to that identifying information about the patient, so that their people's identity remains confidential.
I think it's also important to note, I work in healthcare as well. So like I'm a patient, I have that perspective, but I also work in healthcare. And if you are recruited from a center of excellence, every employee within a hospital, they sign consent for privacy. It's very well protected. I know I can say this to people, and if you don't work there, you don't really understand, but I trust Dr. Faughnan. I trust every member of my care team across Toronto with my health information, in part because I do work in healthcare, and I myself keep that patient privacy when I'm dealing with other people. Also, I just wanted to note, to go off of Leslie's point of it does depend on how complicated your life has been since the last call. You do get a call every year, and it can take 5 minutes, it could take 20. It really depends on what happened. I anticipate that my call in the next coming months is going to be quite complicated because the last year has been different. I've had treatments, I've had scans, I need to discuss those with the team. But like I said, in my little spiel, it's such a minute amount of time for this impactful thing that you are contributing to. I mean, we spend more time wasting time on social media with less meaningful things these days. And if you're looking to contribute and feel like, more purpose in your life, or that you're helping out, then it is definitely something that will not take a lot of your time.
Fantastic. Well, that was a very comprehensive overview, and I know there was a lot of information that wasn't shared in there. So if anybody is interested, I have put the link in the chat to the BVMC study on our website, and you can see what the eligibility is, and all of the recruiting sites are there, as well as our information if you want to get in touch with Leslie. So our next question is for Dr. Faughnan. Delphina is asking, if a brain AVM was surgically treated, can she develop another one?
So that's a really good question. So, typically if a brain AVM has been surgically treated and after the surgery, there was an angiogram done to show that it's cured, that there's nothing left over there, then then the risk of any kind of recurrence of a brain AVM at that, of that brain AVM should be incredibly low. The risk also of developing another brain AVM, a new brain AVM, is also incredibly low. You've heard me say incredibly low because it's not zero. I mean, every time we say something doesn't happen, there's always an exception, right? And so it is true, and you've heard it from Leanne today. Sometimes adults do get new brain AVMs, and sometimes those are perhaps small AVMs that we didn't appreciate before. When we redo imaging, we find that, okay, now we can see it. And if we look back, oh yeah, it was there, but it was so small, we didn't realize it. So sometimes that's the case. But I do think in very rare situations, there have been, like I can count on one hand, but there have been adults who have developed new brain AVMs. So I think that each person's follow-up after having a brain AVM, whether it be treated with surgery or other treatment, should be discussed, in detail and every few years, probably with their specialist, with their HHT center doctor or their neurovascular team specialist, to kind of say, when is it appropriate for us to check again? But the risk should be very low. If a brain AVM has been surgically cured, the risk of having another brain AVM should be very, very low.
Great, thank you. So the next question is asking, what are the primary factors patients should consider when trying to make a difficult treatment decision about a brain AVM?
So I think the things that people need to consider are, talking with an expert team who can look at their brain AVM and tell them whether they think that the features of this brain AVM, like the imaging features, are, whether any of them are the types of features that we consider higher risk, or whether they're the types of features that we think are very likely lower risk. So I think talking to an expert specifically about does this have high risk features or low risk features? And then I think the second piece, remember the other half of the equation is, what about the treatment? So sometimes, for example, an AVM is in a location where the treatment would be higher risk. It's like deeper in the brain or something. So if you needed to do surgery for for that particular AVM, that might be much more high risk than you would want to go through, because it's in a location that's risky. So, and other times an AVM might be treated with radiation or with surgery, and it might be in a low risk area. So I think it's a complicated equation, right? So a patient needs to meet with an expert who not only can look at their imaging and help guide them as to whether this AVM has high risk features or low risk features, but the expert also needs to be able to look at all the possible treatment types and have those available, and be able to say, okay, for this type of lesion, the best type of treatment might be this, and this would be the risk. And so if the expert is saying, we could do this type of treatment and it would be lower risk than your AVM is, then that would be the situation where you'd want to consider treatment. Whereas if the expert says we've considered all the treatments, but they all seem to be higher risk than your AVM, we think that AVM is low risk, then that might be the situation where you want to wait and see instead. So I think that's the best that I can explain it. At this point, because we are still we're still very reliant on having the expertise to put all those pieces, the neurovascular expert and team to put all those pieces together. I just want to say one last thing. When I talk about being, the expert having access to the different treatments, what I mean is, and when I talk about multidisciplinary, what I mean is you might not some scenarios you might just be meeting with a brain surgeon. And if the brain surgeon only has surgery to offer, but can't offer, the gamma knife therapy, like the radiation surgery, or can't offer embolization, then they might answer you, I think surgery is a good idea or not a good idea. But that's actually not the question. That's not the answer that you want, right? You want to know whether is there any kind of treatment that would be a good idea? And if so, which type? So that's why you need a multidisciplinary team, because it's different types of specialists that do surgery, that do radiation surgery, and that do embolization. They're different types of doctors. And when you put them all together, you call that a multidisciplinary team. And that's where you can really get the full expert advice.
That's really fantastic advice. And I think that even in our HHT centers, not all of them have specialists in all of those areas. So it's
right.
probably worth making those phone calls or even getting a second opinion from another
right.
center in some cases if needed.
So right, Nicole, you're absolutely right. And I think that people who have brain AVM should know that they deserve to have access to that multidisciplinary neurovascular expert team.
Yes, absolutely. So we have a couple of questions that are really asking about links of brain AVMs to other things. So the first is asking if brain AVMs have any known link to narcolepsy.
To my knowledge, no. I don't know the narcolepsy literature in depth. So I suppose, again, like I said before, anytime we say no, there's always an exception. But from the point of view of the HHT brain AVM literature, there's no connection known at all with narcolepsy. That's not to say that there can't be a person who has both of those problems, or there can't be an exception where we might one day describe a link. But to my knowledge, no described link at this point.
Okay. The other is asking if there's a link between brain AVMs and brain tumors.
Again, no, there's no link that's been described, and none that makes sort of, we always kind of think too, is there a biological plausible explanation of why these two, is it plausible these two things would be linked? I don't think so. It is true that there are some brain tumors that have abnormal blood vessels associated with them, but that's a different thing than a brain AVM. And sometimes brain AVMs are mistaken for tumors and vice versa. So those are the situations where we're thinking about both of those lesions, but otherwise there isn't a connection to my knowledge.
Okay, great. And the last one is asking if vibrations exacerbate AVM problems.
You know what? I would say we don't know. That it's an interesting question, has not been studied. I don't know. I think that there are things we don't understand about why vascular malformations develop where they do in someone with HHT. For example, people with HHT get telangiectasia most typically on the sun exposed areas. So we've always kind of said, well, maybe that the sun injury the sun exposure induces an injury to the blood vessel. And then in HHT, the mechanism of disease is that the blood vessels don't repair in a normal way, and they repair into an AVM or a telangiectasia. So I guess any kind of trauma to blood vessels could result in an injury. And in someone with HHT, that injury to that blood vessel could make that blood vessel turn into an AVM or a telangiectasia. So, I suppose vibrations could cause a kind of injury in the extreme. We don't really typically think about them causing injury on an everyday basis, like the kind of minor vibrations we live with, but I don't believe that these things have been well studied, and in the extreme, I guess it could be an injury.
Okay. And so we just are going to wrap up with two last questions. The one ties into what you actually just sort of spoke about, just asking if telangiectasias are present on a brain MRI, are they likely to develop into an AVM?
So we think that those are likely not to develop into AVMs and that they are low risk lesions. So typically we might sometimes recommend following those lesions, but that's the way they tend to fall into the low risk VM category from what we know from the experience so far. And certainly my clinical experience has and over the last 23 years has been this in that regard as well, that those have been low risk lesions.
Okay, great. And our last question for tonight has also been asked by several people, and just asking, how do I become a participant in the BVMC study? And so I know there's a couple of different ways. Marie, do you want to start with that? And then I think Leslie and Leanne can definitely provide some insight as well.
Yeah, great. I think that there's some links that Nicole has provided about the BBMC and which centers are part of it. But I think the bottom line is that you can either join the BVMC through your HHT center, or if you don't go to a participating HHT center, then you could join through Cure HHT. And I think that if you're not sure, you could talk to Leslie at Cure HHT and find out whether you might be eligible to join through Cure HHT, or whether we can help facilitate you joining through your center.
And I have a question. So, and you don't have to go to a center at all. You could be going to a community physician and participate as well, correct?
Yes. Yeah. So you, even if you attend, if you go to an HHT center every few years, you don't have to physically go there to join the study. They could do it remotely for you. And if you have not gone to an HHT center and you have a community doctor, then you could join through Cure HHT, and then maybe Leslie could give a bit more information about that.
Yeah, so and I'm leslie.perry@curehht.org. So you can email me and I will email you back and talk to you about, find out what your information is, where you're getting your treatment now. I do have a list of the centers that are recruiting, and then there are centers that are not recruiting, and I have a list of those as well. So I'd be happy to talk to you about it. And if you're not even going to a center at all, then I would talk to you about how we, the doctor that we need, the neurologist, or how we're going to get the information to get your HHT diagnosis. I believe Nicole put that in there earlier, that you have to have an HHT diagnosis and a confirmed brain AVM. So that would also be, you would have to see a neurologist to confirm that the presence of that, but it doesn't have to be someone at a Cure HHT, at a Center of Excellence. So some of the people and some people that I've talked to actually have started with community doctors and have ended up going to a Center of Excellence because they weren't really sure they were getting the treatment or the information that they needed. So some people have actually headed in that direction. So it's been, I've talked to people who I haven't enrolled, but I have given information to. So it's been an interesting experience so far, and I look forward to continuing to do it.
Thank you, Leslie. And you're right, like we recommend that everyone with HHT get to an HHT center at least at some point, right? To get screened, and then they can get advice and be managed by their local physician for with follow-up depending on the person. But I think, and so we typically initially were sort of saying, well, we can recruit most people to the study through their HHT centers, but then we wanted to make sure that we were, that we made the study really accessible to other people with HHT and brain AVMs who are not at an HHT center or are not in contact with an HHT center. And Cure HHT has been an amazing amazing resource for the study and for patients to be able to make the study accessible in that way. So that was kind of the thinking of how we've set it up. So we the simplest and kind of standard science way of recruiting patients is through the centers where all of their information is, but we want to make sure that the study is accessible to everyone.
And I just want to also clarify, Marie, that because we do have a lot of international patients on this webinar, or that will watch the recordings once it's posted on the website, that this is an international study. Is that correct?
Yeah, so we have sites in Canada, the US, and in the Netherlands. And so definitely international. And so if you're going to a site, if you're going to an HHT center in one of those countries, then you should, then you very well might be able to join through your HHT center. And then if not, then you may be able to join through Cure HHT.
And I've talked to people in other countries who have joined in that way. So I set my alarm for early in the morning or get up, stay up late at night, so we can make the time zones work.
You're the best, Leslie.
It's been a real trip.
Okay, well, great. I just really appreciate all of your time tonight. We have obviously gone over, but I think the information has really been invaluable, both just learning about brain VMs, also learning about the guidelines and how they should be managed, and then to learn about this study, which, we're very proud to be a part of, and has put out a lot of critical information. And if you check our website, under the study, we do list all of the publications, so you can see what kind of knowledge they have learned so far in these 11 years. And I know there's a lot more publications in the works, so just keep checking back. So on behalf of everyone at Cure HHT, I want to thank you for attending tonight's webinar and staying connected with us. As the only patient advocacy organization funding HHT research, providing education materials to patients and providers, advocating for the disease and expanding treatment centers around the world, we just want you to know that we are here for you. Cure HHT is grateful to the McMahon family and their commitment to pay it forward so that future generations have more effective treatments and ultimately a cure for HHT, because without their financial support, this guidelines conference would not have been possible. And again, I just want to encourage you to continually check our website at www.curehht.org for up-to-date information about the guidelines, clinical trials, patient and physician conferences, as well as future virtual education events. And if you haven't received your complimentary copy of the Comprehensive Guide to Managing Your HHT, let us know by completing the Join Us form on our website or checking the box on the survey that you'll receive at the end of this webinar. So tonight's presentation was recorded, and you will receive a link to the recording in a follow-up email tomorrow. The recording will also be saved in the Cure HHT website resource library, and we encourage you to share this recording with your family and physicians. Again, I want to thank Dr. Faughnan, Leanne Tilley, and Leslie Perry for volunteering their time tonight. We truly appreciate all of your participation, and I hope you enjoy the rest of your evening. Good night.
Thank you so much.
Good night.
Night.